And now start your presentation.
Good evening, everyone. Today, I would like to give a presentation on mechanical axis deviation and some few basic topics on the deformity correction principles. So, just a general reminder of what we like what I have presented in the last presentation. It's I have taught about the mechanical axis of the lower limb, which can be seen in the frontal plane as well as in the sagittal plane. So mechanical axis, as we know, we can draw by mechanical axis of the lower limb by drawing a line passing through or connecting the two center point of the proximal and the distal joint. So of the lower limb, we can draw by passing a line passing through the joints of the hip joint as well as the ankle joint. Then similarly, the anatomical axis is nothing but the mid diaphyseal line, and that also we can here it is shown that it is the mid diaphyseal line of the femur and the mid diaphyseal line of the tibia, and this is in the sagittal plane. The anatomical axis is the mid diaphyseal line. Now next, after joining the mechanical axis and the anatomical axis, we have to line the joint reaction lines. The joint reaction lines, they are there from the hip joint, the knee joint, and the ankle joint. And after the joint reaction lines, we have to draw the angles. So as the sir said yesterday in the last lecture, so we have to remember the four basic angles, which are normally the medial proximal tibial angle, which would be 87. Then mechanical lateral distal femoral angle, which would be 88. Then the lateral distal tibial angle, which would be 89, and the lateral proximal femoral angle, which would be 90. Most of the deformity occurs in the coronal plane. So basically, better if we remember the coronal plane angles and according to the mechanical axis. And just for the completion sake, the sagittal plane, we have the posterior proximal femoral angle as 90 degree, posterior distal femoral angle as 83 degree, posterior proximal tibial angle as 81 degree, and anterior distal tibial angle as 80. So this was just the reminder of what we have gone through the last time. Now, basic coming to the deformity. So, what is deformity? It is a position of a limb joint from which it cannot be brought back to its normal anatomical position. So, it is described as an abnormalities in the length, angulation, rotation, translation, or a combination of any of the above. Then I would like to talk about the malalignment and malrotation. So what is malalignment and what is malrotation? So malalignment refers to the loss of collinearity of the hip, knee, and the ankle in the frontal plane. So if there is a mechanical axis deviation exceeds the normal range, that I would tell further, then it is said to be that it is malalignment. So basically we will talk about the frontal plane malalignment as well as the sagittal plane malalignment. So frontal plane malalignment may arise from four anatomic sources. We have to take into consideration four anatomical sources. The first would be there could be deformity from the frontal femoral plane deformity. Then could be the tibial frontal plane deformity. There could be the frontal plane knee joint laxity, which could be contributing to the deformity. Or fourth could be the femoral or tibial condylar deficiency. This one by one we have to rule out the causative factors, and we will come to know where the deformity is, and we will accordingly plan the deformity correction. So this is a Professor Pele from his book. The photo is taken from the book, and the earlier type from which he used to draw and measure the angles and do the correct deformity planning. So Pele and Testworth in 1992 designed a malalignment test to recognize the malalignment to identify the source of mechanical axis deviation. Mechanical axis test identify only which bone or the joint source contribute to the mechanical axis deviation that is measured. It does not identify the level of deformity in the femur or tibia. That means by performing mechanical axis deviation test, we would come to know that whether the femur or the tibia or the deformity of the distal femur or near the joint or around the joint, what is contributing to the deformity. But exact location of the deformity that would we have to calculate, which I'll tell later in the coming slides. So I would now like to go for mechanical axis deviation test. This is the short form is MAT. So there are four steps in that. The first step is step 0. So first of all, we have to draw the center point. As I earlier said, first we have to draw the center point of the hip, center point of the knee, and the center point of the ankle. And then we have to draw a line passing through the, like connecting the center point of the hip to the center point of the axis. That will give us the mechanical axis of the lower limb. Okay. So mechanical axis of the lower limb normally just passes medial to the around of 1 centimeter, just passes in within 1 centimeter of the medial point of the knee joint. Here it is seen in the center figure. Okay. So and if it is passing, if it is passes lateral to the, as it is here, if it is passes lateral to the center point of the knee joint, it would be termed, then the lower limb is said to be in valgus. And if it is too medial, then the normal parameters, then it would be said, the lower limb is said to be in varus. Okay. So now how can we quantify the how much varus and valgus is present? So for that, we have to mark the center point of the knee joint. Okay, the center point of the knee joint is shown here in the blue dot, and we have to and as we have drawn the mechanical axis, then we have to measure the distance between the center point of the knee joint and the mechanical, and the point where the mechanical axis is perpendicular. So that distance is the mechanical axis distance, MAD. Okay, so normally it is mechanical axis distance is 8 plus or minus 7 millimeter. So if the distance of that MAD, that is mechanical axis distance, is greater than 15 millimeter, then we would tell it is a varus. Okay, the lower limb is in varus deformity, or there is a varus deformity, or the lower limb is in varus. Or if that distance is greater than 1 millimeter valgus, that means lateral to the center point of the knee joint, that means we can say that it is in the valgus. Okay, so this is the first step of mechanical axis. We have to determine whether our lower limb is in varus or valgus and how much we have to quantify. Next, then there is a step 1. Then step 1 is we have to measure the this M suggests that it is lateral distal femoral angle as per the mechanical axis. So the short M suggests it is mechanical lateral distal femoral angle. As I earlier said, the normal range is 88 to 90, but most probably in the normal individual it would be 88 degrees. Okay, so any deviation from there, we could come to know that whether there is a deformity in the femur or in the tibia. So first we have to see the femur and then the tibia. So less than 85 degree, if we get the angle lateral distal femoral angle less than 85. Okay, so we could judge that the femoral bone is a source of lateral mechanical axis deviation. That means it is in valgus. The femur bone is contributing to the valgus deformity. And if it is greater than 90 degree, then we can come to know that femoral bone is a source of medial mechanical axis deviation, or the varus. Next, after the next step would be to see for the whether there is tibia any contributing to the deformity or not. So for that we have to measure the MPTA, that is mechanical proximal tibia angle. Okay, for the convenience purpose, the anatomical and the mechanical axis of the tibia is considered as one, though they are not the same, but they are considered as one for all the practical purposes. So there is no anatomic, so no short M or A is denoted. So mechanical proximal tibial angle, as we know, normal it is 87 degree, and the range would be in 85 to 90 degree, but most of the normal individual will have a 87 degree for our better remembrance purpose. So if there is any greater than 90 degree, if medial proximal tibial angle would be greater than 90 degree, then we would come to know that tibia deformity is a source of lateral mechanical axis deviation, that is valgus here. And if it is less than 85 degree, then we can judge that the tibial deformity, basically in the proximal tibia, is a source of medial mechanical axis deviation, that is varus. Okay, so we have first seen the mechanical axis is going into varus or valgus. Then we have seen the whether the femur is contributing to the deformity, and next we have seen whether tibia is contributing to the deformity. The last step would be in the mechanical axis deviation test is we have to measure the joint line conversion angle. As I earlier said in the last lecture, see in the knee joint, we have two joint reaction lines, joint lines, where at the level of distal femur and at the level of proximal tibia. Okay, both the lines are basically for the practical purpose are taken as parallel to each other, but actually they are not parallel, and they form an angle of 0 to 2 degree, 0 to 2 degree, which will be coinciding at the medial side. Okay. So normally 0 to 2 degree. The angle between the two lines. What is GLCA is joint line conversion angle. Okay. So normally it is 0 to 2 degree medial side, means that means they converge on the medial side and open on the lateral side. So if medial JLCA greater than 2 degree, if it is 0 to 2 degree, it is okay, it is normal. But greater than 2 degree, if it is forming, then we can come to know that it is varus. And lateral joint line conversion angle. If the joint line converge on the lateral side, and if it is greater than 2 degree, that means we can say that it is in valgus. Okay, so this is the three steps or four steps of the mechanical axis deviation test. And outside the norm, what does this indicate? What does this last step indicate? That outside the normal range, loss of cartilage height or ligament laxity could be the cause of deformity. Okay, so these are the four steps of mechanical axis deviation test. Step zero, as I said, we have to draw the mechanical axis and quantify general varus or valgus. Then step one is to find out femoral defect or the cause of the contribution of the femoral factor in deformity. Then the proximal tibia and the deformity, or the tibia and the deformity, and then the if it is in the anything problematic in the joint, whether the cartilage height or loss of cartilage or the ligament laxity. That way, we have come to know about the causes of mechanical axis deviation. Next, then there are two rules. Along with this, we have to check the while planning for the deformity correction also. First is we have to rule out the knee joint subluxation. That whether the knee joint are subluxated medially or laterally by this way. How we can judge? How we can predict that? Then we have to compare the midpoints of the femoral and the tibial points. Normally, they should be within 0 to 3 degree millimeter. If it is the, see, these 2 points should be within the 0 to 3 degree, 0 to 3 millimeter, sorry, 0 to 3 millimeter coinciding with each other. If it is more, then we can say that there is a the knee joint subluxation. So normally they should be collinear within the 3 millimeter. If the midpoint of the tibial joint line is more than 3 millimeter lateral or medial to the midpoint of the femoral line, the knee joint subluxation is a source of lateral or medial mechanical axis deviation respectively. So if the tibia has gone more laterally, then it would create a valgus, and if it is gone too medially, then we can judge that knee joint subluxation is a cause of deformity. Next, then another rule we have is condylar myelin may be post-traumatic or any growth defect, growth plate injury in the adolescent age group, or that may lead to condylar defects, and we have to rule out that also, that whether they are contributing to any deformity or not. So for that, we have to compare the joint line of the medial and the lateral tibial plateau with each other. They should be normally collinear. This they should be parallel. They should be at the same level. And similarly, we have to compare the lines tangential to the medial and the lateral femoral condyle, and they should be also be collinear, as shown in the diagram. If the tibia, this line should be parallel, and femur also this should be parallel. If any line is above or below, we can come to know that the condyles are a factor of deformity. So these are the four steps, and the plus the two rules, extra rules, which are mechanical axis deviation grossly. Okay. So this completes the mechanical axis deviation test. So mechanical axis deviation test, mostly generally most of the deformities are in and around the knees. In majority of the cases, we see the deformities around the knees. Malrotation of the ankles and hip also contribute, but they contribute to a very little or no mechanical axis deviation, because the deformity in the proximal femur or in the near the ankle are very near to the ends, and mostly they leads to no mechanical axis deviation. So mostly we'll concentrate, and mostly whatever the cases with deformity, mostly around there the deformities around the knee, whether the deformity could be in the distal femur, proximal tibia, or around the knee joint. But while planning for a deformity correction, we have to rule out whether the proximal femur or the distal ankle are not contributing to any deformity. And for that ankle joint orientation, similarly we have to rule out any deformity by measuring the normal angles. If the patient's X-ray and angles come out to be in the normal range, then we can rule out that ankle and proximal femur are not contributing to the deformity. So from medial mechanical lateral distal tibial angle and anatomical lateral distal tibial angle, and similarly the proximal femur angles we have to rule out. Next, so this is the in short the mechanical axis deviation test. Next, the as I said, mechanical axis deviation test only tells us about which bone in gross contribute to the deformity. Now, at which level and how much is the deformity? So quantification is done using the method, using the other method, like in the other method in the sense we can come to know by cora. So, what is cora? So, cora is center of rotation of angulation. So when a bone is divided and angulated, the mechanical and anatomical axis of the bone are also divided into proximal and distal segment, as in you can see in the figure, maybe post-traumatic or maybe malunited or maybe congenital deformity. When the bone is divided, the proximal and the distal part of the bone also will get individual mechanical and the anatomical axis. The pairs of proximal and distal axes align, intersect to form an angle, and this point is called cora. So when we joint the mechanical axis or the anatomical axis of the proximal segment of that bone and the distal segment of that bone, and the joint and the point of that intersection is nothing but it is a cora. And what is the apex of angulation? Apex of angulation is the point where maximum angulation of the deformity is there. It is called the apex of angulation. Okay, and then later I will tell what is the bisector line. But for right now, it is the cora and the angulation, apex of angulation. Next. So how we can quantify the cora and how to proceed is like step zero. Again, we have to first, as we have done the mechanical test. Now we would like to quantify whether how much is the deformity present, what angle, where it is present. Then we have to quantify that. So in the diagram, you can see it is in the mid segment or in the proximal segment of the femur or in the tibia or in the distal segment. Anywhere we can quantify that. So for that, step zero is we have to do the malalignment test. Then step one, we have to draw PAA, that is proximal anatomical axis and proximal mechanical axis. And step two is to draw distal anatomical axis and distal mechanical axis. Then step three is decide whether there is a uniapical or multiapical angulation. Mark the coras and see while planning a deformity correction, it is not that we have to plan with the both by drawing according to the mechanical axis or the anatomical axis. We can go by anyone as per our feasibility. So either we can draw the anatomical axis and we can plan accordingly, or we can draw the mechanical axis and plan accordingly. So in this, what I mean to say by this slide is, see in this tibia, there is an anatomical axis of the proximal segment, anatomical axis of the distal segment. So line of intersection, point of intersection will be the cora, and this angle would be nothing but the magnitude of that deformity. Okay, so this angle is nothing but the magnitude of deformity. This is going into varus, so this would be we can come to know that it is for this example purpose it is taken as 30 degree. So and from this there could be uniapical deformity or be multiapical deformity. Multiapical in the sense that could be one or more coras. There could be deformity in the proximal segment and the distal segment. There could be in the mid segment or the distal. So by joining the lines of each segment, we can come to know how many coras are there, and we can stage like it is a uniapical or multiapical. That will help us in deciding the osteotomy later and plan the deformity. Next. So this is all about coronal plane deformity and how we can plan in the coronal plane. But sometimes the deformity cannot be in the only one plane. Majority of there in the coronal plane, but maybe the we'll get sagittal plane deformity also, and later the oblique plane deformities also. We will be getting deformities. So I would like to talk about a few points on the sagittal plane deformity. So sagittal plane alignment of the hip, knee, and the ankle changes with the normal motion and the gait. The line from the center of hip, rotation of the center of hip to the center of rotation of the ankle is the mechanical axis of the lower limb in the sagittal plane. When the knee is in full extension, see the figure A. If the knee is in full extension, it will passes anteriorly to the center of rotation of the knee joint, which becomes collinear at approximately 5 to 10 degree of knee flexion. So what do I mean to say is, see there is a center of rotation of the knee joint. center of rotation of the knee joint, if you see in the sagittal plane, it is located, if we divide the width of the distal femur in the sagittal plane, it is at the junction of anterior two-third to the distal one-third, or the posterior one-third. So there is the point of center of rotation of the knee joint. So when the knee is in, about when the lower limb is in, or the knee is in full extension, that is straight, it will pass, the mechanical axis will pass just anterior to the center of rotation of the knee joint in sagittal plane. And when the knee is in 5 degree of flexion, it will pass just passing through the center of knee joint. That is the normal orientation. Next. So knee malalignment in the sagittal plane. Now we have to rule out 111 deformity, whether they are contributing to the deformity or not. For that, we have to see whether they are falling, the patient's factors or the patient's parameters are falling into the normal range, and then we can
Yes, can you listen? Yes, can you hear us?
sorry for the interruption. Uh, so I was talking about the sagittal plane deformity. So sagittal plane deformity. Now we are. I'll continue. So we have to basically rule out whether there is a flexion deformity in the knee or if there is a hyperextension. So flexion malalignment is present when the mechanical axis of the lower limb does not pass anterior to the center of the knee joint in maximum extension. See the figure one. In the knee in the full extension, the center of the mechanical axis in the lower in the sagittal plane does not pass anterior. It means it passes posterior. That means there is a flexion deformity. And extension malalignment is present when the knee can be hyperextension more than 5 degree, or basically it passes more anteriorly than the normal. So then it may come to know that there is an hyperextension deformity. Or the second way to correlate this or to find out this is in the lateral view, anterior cortical line of the femur and the anterior cortical line of the tibia. We have to draw this, and both should be collinear in 0 degree flexion. And when the knee is in maximum extension, if the knee is in maximum extension, if the anterior cortical line of the femur crosses in the flexion, then there is FFD. Here it is, you can see in the figure that the anterior cortical line of the femur and the tibia, they crosses in flexion. That the knee is in flexion. That means there is an FFD, and we have to quantify this degree, and we can
ఎక్స్ట్రా బోన్ అనమాట చూసారు రెండు పక్కల
how much is the knee
లెఫ్ట్ పెయిన్ ఉన్నా కానీ రైట్ కూడా ఉంది ఫ్యూచర్ లో రైట్ లో కూడా
Yes, carry on.
Similarly, anterior cortical line of the femur and the anterior cortical line of the tibia, if they cross in extension, then we can come to know that the knee is in hyperextension. Normal 5 degree up to 5 degrees considered as normal. Then we have to rule out, as in the earlier, we have to rule out the knee plane deformity, like any deformity arising from the distal femoral condyle or in the proximal tibia plateau. Then we'll take I'll cover in the short. So knee joint malorientation. The joint orientation of the distal femur and of the proximal tibia is measured adjacent to the anatomic axis by using the posterior distal femoral angle. So normal is 83 degree plus or minus 4 degree, and posterior proximal tibial angle, that is 81 degree plus or minus 4 degree. So any deviation from this would lead us to know that whether the condyle is a cause of distal femur condyle is a cause of deformity, or when the proximal tibia is a cause of deformity. So we have to remember posterior distal femoral angle less than 79, then there will be overall procurvatum deformity of the distal femoral joint line. And if posterior distal femoral angle is greater than 87 degree here, then there will be overall recurvatum deformity of the distal femoral. Next, now we will see after seeing of the distal femur, we will see of the proximal tibia. So if the posterior proximal tibial angle is, as I said, it is normal 81 plus or minus 4 degree in the sagittal plane. So if it is less than 77 degree, there is a overall procurvatum deformity which is the cause of which is there is a cause in the proximal tibia. And if it is greater than 85 degree, then there is overall recurvatum deformity, and the cause of which is the proximal tibia. So this way, we have to one by one rule out what is causing the deformity and accordingly plan the deformity. Similarly, as I earlier said, hip joint malorientation, we have to rule out whether any hip joint malorientation, hip joint is proximal femur is taking part in the deformity or not. So it is anatomical posterior proximal femoral angle is normally 90 degree, and the anterior neck shaft angle is normally 170 degree plus or minus 5 degree in the sagittal plane. So any and the proxen, as we know that the femur is not a straight bone in the sagittal plane, it has an anterior bow. So the normally it is an anterior bow. So the degree between the line anatomical line passing of the proximal segment and the distal segment, that will make an angle of 10 degree. Anything larger than 10 degree would be abnormal, and any angle deviating from this normal value will cause a will lead to the deformity from that particular part. And similarly, as I said, ankle joint malorientation, we have to know the normal anterior distal tibial angle at 70 degree, and anterior distal angle is less than 70 degree or greater than 85 degree. If any deviation from this would lead to deformity. Now, similarly, the cora in sagittal plane, we have to draw the mid diaphyseal line, that is the anatomical axis of the diaphysis of both the bone. And similarly, in the as we have seen in the coronal plane, similarly in the sagittal plane, and decide whether the joint orientation angles are normal for tibia and femur, and we have to accordingly plan our deformity, and we can come to know whether uh, there is a sagittal plane deformity and where is the deformity present. And similarly, we have to mark the cora and get the magnitude. Now the last, now the combination of the deformity could be present like oblique plane deformity. Oblique plane deformity means the deformity can be present as a combination both in the coronal plane as well as in the sagittal plane. So the apical direction of the oblique plane angulation is either anterolateral, anteromedial, posterolateral, or the posteromedial. So we have to quantify that also. But if the radiograph could be obtained exactly perpendicular to the oblique plane, the magnitude can be easily calculated. So what do you mean by say if the oblique deformity is then and we get the and we keep the we get the X-ray exactly perpendicular to it, then we get the we can quantify the deformity. But basically we get AP and lateral view as a standard view. So from that we have to quantify the oblique plane deformity. So oblique plane deformity, we have to magnitudes on the AP and lateral radiograph we have to take, and there is a formula that's the under root square of AP magnitude square plus lateral square, the value in the lateral deformity and the AP deformity, what are the magnitude. We have to square them, and under root of that will give us the oblique magnitude, oblique deformity magnitude. Then another thing which is important is translational deformity. So translational deformity, as the picture shows, is refers to the displacement of the deformity. It occurs secondary to the fractures or maybe secondary to the osteotomies. So for translation deformity, we have to know the which plane it is going, direction, level, and the magnitude. How much it is translated, at what level, proximal, middle, or the distal, and in which plane it is going. Now, after planning further this deformity correction, like we have come to know that whether the femur or the tibia is taking part in the deformity or the knee joint is taking part, condyles is taking part. After ruling out everything now and quantifying the cora, that how much deformity is the present, then accordingly we can plan our deformity correction. So basic of that deformity is the osteotomy. So osteotomy concepts. So basically, there are two basic types of osteotomy for angular deformity: angulation only deformity and angulation with translation. So angulation could osteotomy would be opening wedge and closing wedge, and angulation with translation, if you want translation also, then it will be circular or the dome shape and the oblique cut. Now, one important parameter which has to be seen here is to be known is the axis line around which the correction is performed is the angulation correction axis. So as I said earlier, cora is the maximum, the point at the maximum deformity, and the line passing through it is the angulation line. the axis ACA, that is angulation correction axis. This is the axis where the correction will take place. That will be passing through the cora. Will come to then the osteotomy concept, that's the same. The line passing to the cora dividing the transverse plane into two equal parts is called the transverse bisector line. So we have seen the cora, then we have seen the axis correction axis, angulation correction axis, and there is a one bisector line. The bisector line is the line which divides into two transverse plane. Okay, and each point on the so there it will this transverse bisector line will make us can will give us a cora at the three different level. That means we can consider cora at any of the point in within the bone, means in the this cortex, in the center, or over this cortex. Okay, the result will be same. Now the osteotomy concept, which are very important while planning a deformity. So the first rule is when the osteotomy and the angulation correction axis pass through any of the cora, then there will be realignment occurs specifically without any translation. What do you mean by say? What do I mean by this is when the osteotomy, that means see we have got fora here and ACA, that is angular correction axis here. So when we plan our osteotomy and angular correction axis, angulation correction axis passing at the same level, and when we go for any opening wedge or closing wedge, then we will get the deformity corrected without any translation. As you can see in the picture, this is the deformity. We can give this is opening wedge osteotomy we have planned. Okay, and after opening wedge osteotomy and removing, and then after at the final correction, we will get this without any translation, we will get a straight bone. So this is rule number one. So when the osteotomy and the angular correction axis pass through one of the cora, that is one of the cora, that means it is in the same line, then that means after correction of the full deformity, we will get a straight bone. Next, then the rule number two, when the angular correction axis passes through the cora, but the osteotomy is at the different level, the axis will realign by angulation and translation of the osteotomy. What do I mean to say is that when the angle of correction, angulation correction axis and the cora are on the same level, but sometimes it is that deformity is very much near to the joint. That means we can't, in that cases, we can't do deformity very near to the joint because we will not get the result, and there could be secondary deformity developing. So we have to plan deformity at the other level. See, in this case, it is deformity is planned here, this step, and angle of correction axis, angulation correction axis, and cora are on the other level. So when we do in this way, we will get a correction of the deformity. Like we will get the axis angular correction deformity, but we will get slight translation. That we have to accept, and that accordingly we have to plan our deformity correction. So that is rule number two. Then the rule number three, when the osteotomy and the angular correction axis are at the level above or below the cora, the proximal and the distal axis of the bone will be parallel, but translation deformity will result. But in this case, what happens is cora is at one level. In this case, the cora is at one level, but deformity and the axis, that is angulation correction axis, which we are planning for the deformity correction, is at the other level. It could be above or it could be below. In that case, after full correction, we will get straight bone, but there will be some translation. The proximal and the distal fragment would be parallel to each other. They will not be perfectly aligned, but they will be parallel, and they will have slight translation. So these are the basic three rules of the osteotomy, which we have to plan accordingly and according to our requirement. Whether, and for that we have to look for the cora and where the angular correction axis we would like to plan. So now I will go fast about opening wedge osteotomy. There are basically four types of osteotomy. Opening wedge osteotomy. So the cora, what do you mean by opening wedge also in the theoretical words? The cora and the angular correction axis lie on the cortex of the convex side of the deformity. See, for the tibia, if we say this is a deformed bone, so this would convert in, this would be a concave surface of that surface of the tibia, and this would be convex surface of the tibia for this deformity particular bone. So when the deformity when the osteotomy is performed on the this convex surface, so we will get an opening wedge osteotomy, and after correction gradually with the help of Ilizaro, after performing osteotomy, we will get a straight bone. So this is the cortex on the and what happens here in the cortex on the concave side of the deformity is distracted. So concave side is distracted and convex side is compressed. So this is a opening wedge osteotomy, and opening wedge osteotomy uh, always leads to the mostly final bone length. With it will restore the length or may slightly increase the bone length. Next would be closing wedge osteotomy. Closing wedge osteotomy is exactly the opposite of opening wedge osteotomy. The cora and the angle of correction lie ACL lie on the concave surface of the deformity. Here it will be here. So it will be like here, and we have to closing wedge osteotomy. We have to plan closing wedge osteotomy. So in that way, the cortex side, the cortex on the concave side of the deformity is compressed here. With the cortex on the concave side, the deformity is compressed, and the uh, cortex. Sorry, just the concave side will be compressed, and the opposite side will be distracted. Uh, Only the concave side will be compressed. So that would give us a closing wedge type of focal dome is a osteotomy done in the shape of the dome. With the generally we can use the plate also by our plate is put, and then the plate is moved in a circular fashion, and by multiple tree rolls we can get the focal dome osteotomy. So the osteotomy is a cylindrical shape, three-dimensional osteotomy it is, and the osteotomy site can be passed through both the cora and the correction axis. Thus, translation will occur when using a dome osteotomy. And again, in the focal dome osteotomy, there would be some translation. Then there is a translation deformity correction, which would be transverse cut osteotomy, oblique cut osteotomy, or the multiple osteotomy. And last, the length correction. So after doing all the osteotomy and planning, so we have to gradually distract using, if it is a linear deformity, if it is transverse or the oblique deformity, we can distract it with the LRS, or with the help of Ilizaro system, we can distract the deformity and get our results. So this is the book of Broad Pelly, which I'll just show one example, one or two example of the deformity. It's from our from GS Kulkarni sir. It's his cases, and I with due permission I've taken the photos and X-rays. So this was a 17-year-old boy having a deformity, so varus deformity. So if we plan, so there will be the deformity is very near to the joint, as I said mentioned earlier. So this we have got cora, and 40° is what we get. So near the joint, we cannot do the osteotomy very near. It is just as a condyle deformity is just the condyle. So we cannot do the osteotomy here. So we have decided to plan an osteotomy at a other level. That means in the diaphysis level or metaphysis diaphysis level. So we have done the osteotomy here, and see, you can see the X-ray. We have done the osteotomy here, and we are gradually distracted. And so final X-ray would be, see, the deformity is corrected. We have got a straight bone, but there is some translation which patient will accept, and there will not be much problem to the patient. So there would be, as the osteotomy rule, it is osteotomy number 2. Similarly, this is a sagittal plane deformity. The patient was having a sagittal plane deformity, procurvatum deformity, as you can appreciate. And there is, sorry, this is oblique plane deformity. There is procurvatum also, and there is a valgus deformity also. So again, we have planned an osteotomy and gradually distracted using a Lizaro. Sorry, final X-ray. The final X-ray is not, sorry, sir. Hello.